So I was asking you about an interesting case. So I instead of doing something rare or complicated, I thought I'd go something that we actually discussed earlier. Dr. Blake was supposed to moderate this. I'm just going to wait for Dr. Blake to be ready.
Just finish your case, and we'll have question and answer from Dr. Beck and Dr. Gendry afterwards.
Okay. So yeah. So we're gonna start. So I'm going to ask you. So I have a young female patient who presented with a large mass, compressive symptoms. She had a large cyst that was aspirated a few times, and it's a cyst, so not diagnostic. A thermal was not able to be done, but they did an interface with a low risk. The patient is Thyroid. Again, this is the pathology report, non-diagnostic versus a cyst. And as you can see here, the mass, it's a large mass, and a little bit of a CAT scan, and you can see here a video of how the CAT scan looks. It's approximately like 130 ml, and you can see the mass is significantly large, extending superiorly, pushing the larynx all the way to the left. Trach is completely deviated to the right side, so the left thyroid mass cystic. The trach is completely deviated and recompressing the esophagus and is extending a little bit below the clavicle to the subclavian vessel. So it's a significantly large one, aspirated multiple times, and it recurs like the same night or the next morning. The patient says when she sleeps and she feels it and she wakes up and the mass is already back. So I did the evaluation that I did, and I can see the pictures before and after, but I have a few questions. I did a little trick here, and Dr. Blake has some opinion on this and published on this topic, with the issue of the ethanol versus RFA. So my questions to you, would you just do RFA or ethanol or both? And I have issues regarding, questions regarding the technique. So I witnessed many other providers that will do a full aspiration. Some will do almost near but leave it, because if you aspirate the whole thing, it disappears, you do not see it. And some even like fill it back with some saline to see the wall, so you can really, because you want to make sure you ablate the whole wall. And if you use ethanol, it's very controversial. How much do you use? And also, I'm going to ask you a question, then you can answer everything at one time. Would that be okay? I'm going to be out. I'm going to let you answer all. Do you leave it inside too after the injection? You re-aspirate? Because there are some studies that maybe show there is no difference between both, but everybody's different. And I've seen people use sclerosing agents. I want to hear about your experience. And I can tell you what I've done here, but I want to hear from you what you do.
Can you show the ultrasound imaging?
So I do have the CAT scan here. I don't have the ultrasound. I do have the CAT scan. I thought the CAT scan was just a little bit more impressive.
It seems to be predominantly cystic, is it?
Yes. It's cystic.
If so,
it is a cyst.
I will completely aspirate first, and then do cytology, and then wait. If it is refilled, enlarged again, I will try ethanol.
You will try what?
Ethanol.
Okay.
Ethanol would be effective for this region. Any other?
I think there is a methodology which is published about the quantity of ethanol. So all agree about the fact that you have to re-inject just half of what we have aspired, and not beyond 10 mL. Otherwise, you get the patient drunk. That's true, especially in ancient lady. That's true.
Well,
second one, I agree with you that some, because the idea is not to leave it the intention, that collection. And the second one is true that some aspire a little bit, others leave everything. We inject half of what we aspired and leave it. And when we come out, we inject some lidocaine. Some others don't do it. I think it's a good idea because when you come out, you inject, you avoid alcohol from coming back with the needle, and give a little bit anesthesia in that part, which then can be hurting. No other data are solid on other sclerosing substances.
I would agree with both of you are the expert in the world. I'll tell you a little bit about the American issue here. Two things. You just mentioned half the volume injected back on the nodule. This will literally cost at least $6,000.
Yeah.
Ethanol is expensive, extremely expensive. They send it to you in 5 ml. So if you're gonna use just 2 vials, that's what I'm saying. So that's one thing. The other thing, as you know, the problem is with ethanol that you might think you're inside and you're injecting, but it can leak outside, and you are thinking that you are injecting. Leaking of the ethanol outside the nodule. Yeah, there is actually reports on this, and I've done like 60 ethanol in the past before all the ablations, but the problem with ethanol, it can leak, and people actually say that you continue to talk to the patient because the leak can cause some hoarseness. But anyway, the cost in America is a bit, there are a lot of reports about this. I don't know if Dr. Pick, if you will comment on this, but the leak of the ethanol outside.
Is your experience the cost? For us, a box with 5 vials of 10 ml,
5 vials,
each one of 10 ml.
That's literally almost $30,000.
In Italy, probably $30.
Yeah, well, in the US, we only
So
what I've done a good series of write a paper on this actually. Yeah. Well, we used to get from some, but we gotta use things that FDA approved and stuff. So I tell you what I do in my practice. I got a good series of this, and it's working very well for me. That I aspirate, I leave a little bit. I want to see the wall of the cyst, and I do the ablation of the wall with the RFA, and at the end I inject a little bit of ethanol, and I do have no recurrence in these cases.
very little.
Very little, meaning not more than 5 a.m. I'm not using more than that one vial. Otherwise it's not really cost effective.
So you did a population?
I did a combine. I do
Combine.
RFA and ethanol.
Excellent.
That's what I do. Thank you.
So if you were to use just ethanol, for how long do you let it stay in? So you
Leave it.
inject.
Leave it, it will absorb slowly.
You don't aspirate it back?
No, you leave it.
So some people actually, there's a study that looked into this. I mean, people leave it, and I actually leave it. I personally leave it. But in the literature, there's a study that injected and aspirated and showed no difference between the aspiration and keeping it inside. That's the literature. But I leave it personally.
In our
This is expensive. I just paid too much money.
We leave it.
You can reuse it.
we almost always remove the injected ethanol. 2 minutes ethanol injection is enough. 2 minutes. In our study, we compared 2 minutes, 5 minutes, 10 minutes. 2 minutes.
So Dr. Baker, you remove it and you keep it, yes?
Yes, yes.
You keep it.
Dr. King, just one question from the audience.
What's
It's
this?
unrelated to the piece that you showed, but do you have any experience doing biopsy and ablation in the same session?
Biopsy and ablation.
In a case like this, or
Which is
No, unrelated to this case.
So in general,
You're
so
not
the
getting the results.
guidelines initially recommend 2 benign biopsies like treating a nodule before the ablation. Having said that, many providers in the US all okay with one benign biopsy now, as long as it looks okay, etc. In my own practice, if in the hospital, etc., I repeat the biopsy right before as a second one, but not a first one. I need to know what I'm doing before I offer the ablation. So that will be the second biopsy.
Just because if you have the pathologist on site, would that change anything for you?
Well, the pathologists on site, as you know, they can tell you about the adequacy. They can try to look at it quickly, but really the final pathology can be a little bit different. So it's not information specific to this instance. Thank you. Thank you very much.